Today we're going to talk about the gallbladder, and we're going to start on our chapter. It's a very long chapter again because the gallbladder and biliary system is a lot of information. So we're going to go through half the PowerPoint today. Excuse me, I'm still going off over this cold, so I'll try not to cough. Okay, so gallbladder. It's distended, pear-shaped, or teardrop shaped sac. These are the dimensions I want you to know. It can be about 8 centimeters long, transverse about 4 to 5 centimeters, anterior to posterior 4 to 5. Wall thickness is a thing that we measure every single time, so we want it to be less than 3 millimeters. Typical bile capacity is 30 to 60 ml. It's located between the main lobar fissure between the right and left hepatic lobes. This is an image, a sonographic image of the main lobar fissure and by the gallbladder here. Here's another image of this. This should look familiar from your just anatomy. See the gallbladder right here and the bile ducts going into the liver. The gallbladder is divided into the neck, body, and fundus. The neck is the narrowest portion located right to the right of the porta hepatis. The body is the central or main portion, and the fundus location varies. Everybody's a little bit different, but can extend pretty low into the right lower quadrant. Here's a pretty normal looking gallbladder, neck, body, and fundus here, and transverse. We also like to learn about the ducts because that helps us to know if there's any kind of biliary obstruction going on within the liver. So the cystic duct arises from the superior aspect of the neck. The intrahepatic bile ducts in juxtaposition to portal veins and hepatic arteries, which forms the portal triad. The cystic duct is about 2 to 6 centimeters long, joins the common hepatic duct, forming the common bile duct. The common bile duct courses inferior within the hepatoduodenal ligament and anterior to the portal vein to the first portion of the duodenum and the head of the pancreas. So this is what it looks like. There's the hepatic ducts forming the common hepatic duct, cystic duct, and then it forms the common bile duct. And then that is, you can see it coursing through the pancreas into the duodenum there. This is the cystic duct entering the common bile duct. Here's a short axis of the common bile duct in the head of the pancreas. Here's the common bile duct here with the hepatic artery up there. Here's another really pretty picture of the portal vein. Then the hepatic artery runs perpendicular to the portal vein. And then you can see the common bile duct to the right. Before that, this is the common hepatic duct. We measure the duct inner wall to inner wall. The common hepatic duct typically does not measure greater than 6 millimeters. Common bile duct typically does not measure, should measure less than 7 to 8 millimeters. So I want you to know those two things. As we get older, duct size increases about 1 millimeter starting at for every decade of life, starting around 40 to 60 years of age. So as we get older, it gets bigger in size. Here's an intrahepatic duct measuring less than 2 millimeters. See how they're measuring inner wall to inner wall on figure C. So this is the common hepatic duct to the left of the little hepatic artery and common bile duct to the right. Which gallbladder division is usually located to the right of the porta hepatis? If you said neck, you're correct. Which bile duct carries bile from the cystic and hepatic duct to the duodenum? From the cystic and hepatic duct to the duodenum. If you said the common bile duct, you are correct. All right, let's do sectional views. I don't know why it says kidneys up there. Okay, so sectional views. Plane A is an axial view near the neck. You can see that it's smaller and more narrow. Plane B is through more of the fundus. You can see it's thicker. And this is what it looks like over here and C. Here's a pretty picture of a gallbladder scan through long. This is a sectional view through okay. So the transverse plane A is the relationship of the gallbladder with the proximal common bile duct and the portal vein. So we're up here, or so it's pretty tiny up there. And then B is through the pancreas. This is a sectional view looking at the common bile duct, hepatic artery, and portal vein, and common hepatic duct. So common hepatic duct is superior, and the hepatic artery runs perpendicular to that. Then it becomes the common bile duct, and the portal vein is running parallel with the common bile duct. Variants. Common gallbladder variants include different shapes, positions, and folds and septations. Gallbladder may contain small infundibulum at the neck, Hartmann's pouch, where stones can collect. A Phrygian cap is common when fundus kinks or folds back. I have a Phrygian cap. I'm sure one of you guys do too. This is an image of a junctional fold. This is a normal variant. The gallbladder can be mobile, ectopic, kind of left midline transverse, low in the right lower quadrant, completely surrounded by peritoneum in the abdominal wall. So it most of the time is where it needs to be, but if you don't see it there and they haven't had it removed, you might want to start looking more lower in the right lower quadrant. This is what a Phrygian cap looks like. It's like at the superior that it folds on top of each other, almost like a seahorse. It's so cute. Which of the following appear on a transverse image obtained at scanning level A? Is it the right hepatic duct? Is it the proximal common bile duct? Is it the proximal cystic duct or the portal confluence? Where they come together is going to be common bile duct. Biliary system functions. Transports bile produced by hepatic parenchymal cells to the duodenum to aid in digestion. Bile contains bile pigments, bile acids, cholesterol, lecithin, mucin, and other organic or inorganic substances. Bile helps emulsify fat, promote fat absorption, and facilitates action of lipase enzyme. Biliary system functions. Gallbladder concentrates and stores bile. Gallbladder regulates biliary pressure, and gallbladder contracts. Food enters the small intestine. Cholecystokinin is secreted, and the gallbladder contracts. Contraction can be induced by fatty meals or IVCCK injections. Bile is released into the cystic duct, flows through the common bile duct, enters the duodenum. So when we start scanning the gallbladder, we're going to need you to not eat, because if you eat, especially if you're eating like a fatty meal, like cheese or milk or, anything with a lot of fat in it, it really does, and the bile duct does contract, and we won't be able to see it. Diminished gallbladder emptying. Some patients with cholelithiasis cannot empty their gallbladder, and that causes pain. There's lab tests to evaluate pathophysiology. White blood cell count, increased value indicates the infection. AST and ALT enzymes produced by liver and other tissues of high metabolic activity. AST, in particular, ALT enzymes can be mildly moderated, elevated biliary obstruction. So LDH can be mildly elevated in obstructive jaundice, and ALP is marked increased in obstruction jaundice. So if they have elevated LFTs, which is liver function tests, it could be potentially because of a gallbladder issue. Bilirubin results from the breakdown of hemoglobin in red blood cells. Direct or conjugated bilirubin tends to elevate in obstructive jaundice. So bilirubin is what makes you yellow, basically, if it's not going out of your body like it should. If mildly to moderately elevated, which enzyme function value is better indicator of biliary obstruction? So if ALT is elevated, it is a better indicator of biliary obstruction. So B is correct. So this is what you got to do when you're going to do a gallbladder. The patient needs to be NPO for at least 6 to 8 hours. The ideal prep prior sonography exam. So they shouldn't eat after midnight, basically, and they should have a test early in the morning. Fasting distends the gallbladder and reduces bowel gas. So sometimes in emergencies, though, we can't do that. So if they come in and they're in a lot of pain and they had just ate like 2 hours ago, we're still going to scan the gallbladder, but it could be potentially contracted. So that's something that has to be taken into consideration. So the normal gallbladder has thin echogenic walls, anechoic lumen, and posterior enhancement. Bile duct lumen should appear anechoic. Avoid artificial fill-in. We already talked about where the gallbladder is located. You need to document the gallbladder, the portahepatis, the intrahepatic and extrahepatic biliary systems. And you want to make sure that you're clearing out your gallbladder, because sometimes it can, you can deal with reverberation because it's so anechoic. So you want to make sure that you're using your TGCs and your overall gain to make sure that it is cleared through and there's no artifact. Harmonics we can use, and it is a button on your machine and it reduces artifact within. So this is an image of without harmonics, And this is the image with harmonics. You can see it's just a little bit clearer, and you don't get that white artifact in your gallbladder. Here's another image. This little white echogenic theme that's shadowing, that's a stone. So for the examination, you'll do the patient in two positions, supine and then left lateral decubitus. You'll position the patient to demonstrate gravity dependence of calculi. So if there are stones, we'll roll the patient. And the crazy thing is sometimes you can watch the stones roll around in the gallbladder, which is kind of nuts. If echogenic foci are seen within the gallbladder and does not shadow, attempt several techniques. Reduce gain distal to foci, increase transducer frequency, or change scanning angle to decrease distance between ultrasound beam and calculi. Murphy's sign is determined if present. Evaluate by applying transducer pressure directly over the gallbladder. If a patient is in pain during that time, it's called a positive Murphy's sign, and it's focal pinpoint tenderness. So if you're doing an ultrasound on a gallbladder and you can see some stones and you press and they're like, oh my gosh, that hurts so bad right there. That's what we call a positive Murphy sign. And that can help us determine if the gallbladder is inflamed or there's some kind of infection like cholecystitis. Doppler evaluation valuable to interrogate gallbladder and biliary structures with color or pulse Doppler. And it's helpful in evaluating hyperemia and inflammatory conditions, distinguishing solid masses, differentiating intrahepatic and extrahepatic bile ducts. A fatty meal may be needed to confirm an obstruction by observing changes in the duct size or to evaluate gallbladder contractility and emptying. Patients with stones tend to not empty their gallbladder as much. Which is the correct statement regarding calculi in the gallbladder? Increase the speed of insonating sound. Calculi should produce a clean shadow. Reduces fill in artifacts in common bile duct. No shadowing is seen with echogenic foci. Calculi should produce a clean shadow. So if you said B, you are correct. What is noted if there is a focal pinpoint tenderness when the transducer pressure is directly over the gallbladder? It's called a positive Murphy sign, D. Gallbladder anomalies are rare. Most probably occur between the 4th and 12th gestational weeks. Some defects can predispose a patient to bile stasis and attacks of cholecystitis. Attack themselves have no unusual aspects. Symptoms call attention to anomaly. So septate gallbladder may result from a congenital mucosal diaphragm, adenomyosis, or a combination of the two. Gallbladder normally develops by cannulation of blind sac. Gallbladder septum may be an incidental finding. So a single septum is going to appear as a thin linear echo separating the gallbladder into compartments. Simple junctional folds may mimic a septum, but it's different. One of the rarest congenital gallbladders is like a multiseptic gallbladder. So these patients that have this may have some issues. Fine linear septa or honeycomb pattern of clustered septations resulting in multiple communicating cyst-like compartments. Septa may cluster in the neck and body region of the gallbladder. Differential diagnoses include desquamated gallbladder mucosa, hyperplastic cholecystosis, such as polypoid cholesterolis, and adenomyomatosis. Interposition of the gallbladder. Absence of the common bile duct and cystic duct is a rare anomaly. The abnormality is the main hepatic ducts drain separately or together directly into the common bile duct. So there's no cystic duct or common bile duct. Then the gallbladder drains directly into the common bile duct. So in this, you probably have a little bit of a biliary obstruction. So a patient could have jaundice, some abdominal pain, and an enlarged gallbladder. This is crazy though, like the right hepatic duct goes into the gallbladder, left hepatic duct, and then the common bile duct goes straight in, but there's no cystic duct. Biliary atresia, this is what I really want you to know, is the most common type of obstructive biliary disease in infants and young children. Destruction of extrahepatic biliary system occurs due to inflammation and angiopathy. Progressive obliteration of the extrahepatic ducts, and in many instances, the gallbladder takes place. Obliteration extends into the proximal intrahepatic duct system, which usually remains patent in the first few weeks of life. More than 50% of neonates have transient jaundice, characterized by mild elevation of serum bilirubin and resolves spontaneously. My kids all looked orange at first. Persistent or sudden onset of jaundice after the first and second week of life may indicate a more serious abnormality, most common biliary atresia or neonatal hepatitis. Biliary atresia is twice as common in males, and neonatal hepatitis is 4 times more common in females. Important to distinguish biliary atresia from hepatitis because atresia may be treated surgically with a liver transplant or a procedure. Outcome is better with early surgical intervention. If surgical correction is not possible, death usually occurs within months, with few children surviving a couple of years. So it's very not good. So in normal neonates, sonography generally visualizes the common hepatic duct and measures it no more than 1 millimeter. Detection of both the intrahepatic and extrahepatic dilatation excludes atresia and indicates obstruction. If gallbladder contracts within 30 minutes of feeding, biliary atresia is unlikely. Large kidneys with increased echogenicity have been associated with some cases of biliary atresia. So choledochal cysts, there's 5 types, uncommon development of anomalies involving intrahepatic and extrahepatic biliary ducts. Type 1 is the most common. It involves a saccular or fusiform dilatation of a portion or entire common bile duct with normal intrahepatic ducts. There's type 2, type 3, type 4, and type 5. Type 5 is Crowley disease. Communicating cavernous ectasia is a non-obstructive saccular dilatation of communicating intrahepatic ducts. So maybe know just what a choledochal cyst is and which type is most common and what Crowley disease is. Clinically, the signs and symptoms of it include intermittent jaundice associated with colicky pain, failure to thrive, sometimes a palpable subhepatic mass displacing the stomach and duodenum, 4 times more common in females than males and often present early in life. Surgical management is recommended for this. So what it looks like on a sonogram is like a localized cystic mass separate from the gallbladder in region of the portahepatis or intrahepatically, depending on the type. So this is not by the gallbladder, but there's a cystic mass right here with the arrows. It's called a choledochal cyst, and this is after a cholecystectomy, so we know that it's not the gallbladder. Which congenital anomaly is associated with persistent or sudden onset of jaundice occurring after the first or second week of birth? If you said biliary atresia, you are correct. And which of the 5 types of choledochal cyst is associated with fusiform dilatation of the common bile duct? If you said type 1, you are correct. And which of the 5 types of choledochal cyst is associated with Crowley disease? And it is type 5. So know the most common kind of choledochal cyst and know what Crowley disease is and which type of choledochal cyst is that, which is type 5. I'm going to go over a couple more diseases and we'll be kind of done for today. So with biliary sludge, that's going to be something that we see quite a bit. And it just kind of represents precipitates that have formed in bile. So when we see the formation of sludge, we should definitely think that it is abnormal and we should note it. Pathogenesis, clinical significance, and prognosis remain uncertain. Some people can just have some sludge and it not have any pain, not have anything, but you do want to mention it in your report. But it can also cause gallbladder pain. So another way that you can determine that is by doing the positive Murphy or doing the Murphy sign where you press just a little bit to see if that part's tender. So if a patient comes in with biliary sludge and positive Murphy sign, then you'll want to write that in the report because it could be a precursor for gallbladder disease. May be caused by different conditions. So prolonged fasting, if they haven't eaten for a while, TPN, bile stasis, pregnancy, rapid weight loss, or recent surgery. What it looks like sonographically is it's going to produce homogeneous, low amplitude, non-shadowing echo patterns. So it's just going to look like white, more hyperechoic area in the bottom of the gallbladder. So it forms like a fluid level that remains constant in long and transverse images and slowly moves with patient's position. This is different varying types of sludge. I think you can see it best in image B, where you can see like the fluid level in the gallbladder, and it's just like more of a hypoechoic echo texture. This is some sludge in the bile ducts. This is a gallbladder that is full of sludge. I do feel like I like probably 25% of the time just see a little bit of sludge in a gallbladder. But it is something worth mentioning. Tumefactic sludge from a long-standing biliary obstruction frequently does not layer, but often resembles a polypoid mass that can mimic a gallbladder neoplasm. So color Doppler can be useful in determining sludge versus neoplasm. Sludge isn't going to have any kind of vascular flow, while neoplasm would. Sludge balls. I like that word. Sometimes you'll see little sludge balls. Difference between those and like a gallbladder stone is, well, first, they're not going to shadow. So gallstones shadow, while sludge balls do not shadow. And they're a little bit not as echogenic. Here's some sludge balls. Sludge can be found in conjunction with gallstones. So this is a sludge-filled gallbladder with gallstones, and the gallstones you see are shadowing. Using too high of gain settings fills the gallbladder with artifactual echoes. So you want to make sure that your gain settings are good and your TGC is not too high or low. So what is the most likely explanation for echo artifacts that partially or completely fill the gallbladder and create a false appearance of sludge? If you said excessively high gain settings, you are correct. Cholelithiasis is the next thing we're going to go over, and it's gallstones. They can be large or small, single or multiple, symptomatic or silent. Common, approximately 20 to 25 million American adults have gallstones. Prevalence is higher in females than males, and occasionally seen in fetuses and children. Major calculi contain a mixture of cholesterol, bilirubin, and calcium. 75% of gallstones in the US are primarily cholesterol, and many factors are associated with gallstone formation. This is a baby, like their gallbladder is filled with stones and a fetal ultrasound. So you can see that the stones in this little baby and a neonate are in the neck of the gallbladder. It's multifactorial why people get gallstones. I would say that the prime cholelithiasis candidate is female, fat, fair, 40, fertile, and flatulent. So um, just remember that. And I've remembered that for years and years and years. And I didn't think 40 would ever come. But now, almost knocking on 40's door, I'm like, oh my gosh, I'm becoming a candidate for gallstones. So I gotta just make sure that I'm taking care of myself. Other associated risk findings are ethnicity, genetics, diet, TPN, cirrhosis, diabetes, pregnancy, rapid or weight loss, Crohn's, or various medications. Most 60 to 80% of the gallstones are asymptomatic, which is good. Patients with symptoms generally present with right upper quadrant pain that is steady, occurs after meals, or radiates to the upper back, shoulder, epigastric area, and some patients may have nausea and vomiting. Gallbladder disease can mimic the pain of the ischemic heart disease. So sonography of biliary tree is often worked up with chest pain. So you might do a gallbladder ultrasound for chest pain, and that's kind of why, because it's like can mimic heart disease. So if you get an order for that, that's why. It's not just some weird thing. Elevated alkaline phosphatases and mildly elevated AST and ALT levels when the cystic duct or CBD is obstructed. So small calculi tend to be more serious because they may exit the gallbladder and cause ductal obstruction, and persistent symptoms may require surgical intervention. A lot of people get their gallbladder removed because of stones. So our classic appearance, sonographic appearance of this is mobile. So they move within the gallbladder, gravity dependent. So if you roll them onto the left lateral decubitus, they're going to fall down to the left side. Echogenic foci with gallbladder lumen with posterior acoustic shadowing. Most are over 5 millimeters. Um, they're more difficult to see if they're smaller. And small stones that which I have seen that aren't just like that normal like echogenic appearance, they appear more like gravel. So like multiple stones. So sometimes you'll see the whole bottom of the gallbladder just shadowing. And what's happening is there's those small stones and they're kind of like a sand appearance. The majority of stones produce clean shadows with distinctive margins because they are highly reflective. And it makes it really easy to see. Here's some different stones. This is a large stone in the gallbladder of the fundus. This is a mixture of small shadowing stones along with sludge. There's some tiny stones that could exit the duct and see multiple shadowing dependent stones within the gallbladder. And D, layering irregular stones, and E, and single small shadowing stone, and F. So this is a picture of like small stones. And I remember one time when I was a clinical student at Wesley, I actually missed these stones. And I went to go do my clinical instructor and I was like, I can't see anything. I don't think that she has anything. Her wall is a little bit thickened. So the clinical instructor comes in, rolls her on her left side, and all these little stones appear. And then she measures the wall again, gets a better look at that. And of course, it's thickened and there's a little bit of fluid. And so this patient was having a horrible bout of cholecystitis and I almost missed it. And I was like, I'm not doing that ever again. So I'm very, very cautious with my gallbladder exams because I don't want to miss something like that. That could be, it's subtle, but it's there. This is a patient scanned in different positions with gallbladder stones. They're going to be moving. Some stones aren't, if they're very large, will not be mobile. So false positive for identifying stone. If you happen to get a bowel gas or the ligament teres, junctional folds, edge shadowing, or other artifacts or scarring or surgical clips, that would be a false positive. False negative using inappropriate technique, transducer frequency, focal zone, or gain setting. Stones within the Phrygian cap or Hartmann pouch are hard to see. Mistaking a thin layer of stones for bowel gas. I think that's what happened with me that one time. And small stones. Everyone was very kind when I did that, like the radiologist and everything, but I felt so bad. All right, the cholelithiasis wall echo shadow triad. With careful technique, visualize wall echo shadow or WES triad or double arc shadow sign. First arc or curved echogenic line represents the thickened gallbladder. Second arc is from the surface of the stone, followed by posterior shadowing. So wall echo shadow. So this is what happens when a gallbladder is filled with stones. You won't see the classic anechoic structure of the gallbladder. You'll see this wall echo shadow triad. With chronic disease, the gallbladder could be so contracted that you don't see it and you just see the shadow. And this is what it looks like. You can see the arrow here. This is going to be the edge of the upper gallbladder, and then you're going to see an echogenic area here, and then you're going to see a shadow. And this is a fluid or like a stone-filled gallbladder. It's called wall echo shadow. What laboratory values are associated with calcium obstruction, either the cystic duct or common bile duct? You said C, alkaline phosphatase. You are correct. Which term describes the double arc shadow sign? Back triad, wall echo shadow triad, harmonic focus technique, or mobile to 2 to 3 and then cholesterol calculi. Said wall echo shadow, you are correct. Acute cholecystitis, inflammation of the gallbladder. This is when people get so sick. Up to 95% of the cases result from an impacted stone with gallbladder neck or the cystic duct, the most common inflammatory condition of the gallbladder. Inflammation may result in necrosis, ulceration, swelling, or edema. Signs and symptoms are indistinguishable and somewhat non-specific, but the patients are going to have right upper quadrant pain. They're going to have positive Murphy sign. They're going to have nausea, vomiting, distension, fever, a palpable right upper quadrant mass, or jaundice. So they're going to be very, very sick. Their gallbladder is infected. Symptoms can be confused with acute pancreatitis, perforated peptic ulcer, liver abscess, or acute alcoholic hepatitis, and the lab values can be non-specific. But having a gallbladder ultrasound will help with this because we'll be able to check and see the wall is, if there's any stones, if the wall is thick, if there's fluid around the gallbladder, so we can help diagnose this part. So sonographic exam, so you're going to have a positive Murphy sign. The gallbladder wall is going to be thick and you're going to have gallstones. You're going to have pericholecystic fluid around the gallbladder. At times, the gallbladder could be hydropic. Cholelithiasis and positive Murphy sign are highly suggestive of acute cholelithiasis. Gallbladder wall thickening, pericholecystic fluid are considered secondary signs. Color or power Doppler may be helpful in detecting hyperemia in a large cystic artery. So this is a patient that's pretty sick with it, and you can see the gallbladder wall is very, very thick. And the gallstones, the wall looks irregular, just not doing good. Increased color flow around the gallbladder. The cystic duct here is still dilated. 60% of acute cases resolve spontaneously. A lot of people will have like a gallbladder attack and they won't go to the emergency room, and then it'll resolve on their own. And that's what's kind of happening there. Preferred perform a cholecystectomy within the first several days of onset. When they just take the gallbladder off, they have a higher chance of not having complications. Clinical onset may precede appearance of sonographic signs by 12 to 24 hours. So they could start having the pain and we wouldn't be able to see anything quite yet. There's quite a few things that can happen if with complications of cholecystitis. I think one of the gangrenous cholecystitis is really bad. Gallbladder perforation. These could cause sepsis and possible death to the patient. So it's more helpful to just get it diagnosed and get surgical intervention. What is the most common precursor of acute cholecystitis? If you said impacted stones in the gallbladder neck or cystic duct, you're correct. Which one of the following are considered secondary signs of acute cholecystitis? Gallbladder wall thickening is.
I didn't know if you were recording or not.
Acute acalculous cholecystitis is when there's no gallstones, but there's still an infection within the gallbladder. It occurs about 5 to 14% of cases. And increased concentration of stagnant bile can be directly toxic and cause overdistension of the gallbladder, leading to vascular compromise. Viscous and stagnant bile can act as functional gallbladder outflow obstruction and provide pathway for secondary bacterial invasion. Majority of these cases occur in patients in the ICU. Multiple other causes include trauma, surgery, severe burns, sepsis, long-term TPN, prolonged fasting, diabetes, or HIV. Clinical signs and symptoms indistinguishable, somewhat nonspecific. Patient presents with right upper quadrant pain, positive Murphy sign. Other symptoms include nausea, vomiting, distension, fever, palpable right upper quadrant mass. Symptoms can occur 24 hours to 50 days after initial event, but usually occur within 2 weeks. Due to difficulty in diagnosis, acalculous cholecystitis has a high morbidity and mortality rate because it's difficult to diagnose. The gallbladder is going to be distended and have a thickened wall with internal debris and sludge. Wall thickening with hypoechoic areas within the wall and pericholecystic fluid can also be seen. Diagnosis is often difficult to do to absence of gallstones. But you should still always be measuring the wall, and the wall, if it's greater than 3 millimeters, should be a consideration that there's some kind of infection, whether or not that there is gallstones. Here is an example of this infection, and you can see how thick the gallbladder wall looks. There's some sludge. You can see the fluid level there, and pericholesistic fluid with the arrow. So there's fluid around the gallbladder, usually with a concerning of like an infection too. Long image of the patient with positive Murphy sign and fever. The gallbladder wall is thickened and swollen with edema. So what history is common in the majority of acalculous cholecystitis cases? You said patients in the ICU. You are correct. Patients with acute cholecystitis are at risk for developing empyema, which is pus, basically gallbladder perforation, gangrenous cholecystitis, and emphysematous cholecystitis. Emphysema emphysematous. I don't know. I can't say it. Cholecystitis. Empyema, pus in the gallbladder. It typically occurs in diabetic patients. You're going to have pus-filled gallbladder resemble sludge, but the patient is going to present with symptoms of cholecystitis more than just sludge, because a lot of people don't have like the fever or positive Murphy sign, or they're not going to have the nausea and vomiting just with sludge. But if you're getting the fever, chills, right upper quadrant pain, and you see like this pus-filled gallbladder, you have to think maybe there's something more going on. Sepsis can be present. Gallbladder perforation affects 2 to 11% of patients with acute cholecystitis. Typically, perforations occur in fundus due to chronic inflammation and low blood flow. Acute perforation is the bile leaks into the causes peritonitis, but it's pretty uncommon. Subacute perforations are more common, where it's in the abscess, result in abscess formation, and abscesses occur in and around gallbladder, liver, and peritoneal cavity. So these patients are so sick. It's very life-threatening, and it has a high mortality rate. Age, delayed treatment, and sepsis are main factors for the increase in death rates. Patients present with right upper quadrant pain, nausea, vomiting, fever, elevated WBC, and abnormal LFTs. So you're gonna have complex fluid collection, irregular gallbladder walls, gallstones, inflammatory changes within the gallbladder faucet, and focal defect of gallbladder wall. The defects in gallbladder perforation can be focal and small, but they could be large. And CT may help with this. Best way to avoid sepsis and mortality rates is just taking the gallbladder out as soon as possible. Ugh. Here's perforation right here. You can see the wall defect in B. You can see that the fluid has leaked out of the wall there. These patients are terribly sick. Gangrenous cholecystitis is due to absence of blood supply or infection. Gallbladder wall becomes ischemic, eventually necrotic, and it develops in about 2 to 38% of acute cholecystitis patients. Patients acutely ill with positive sonographic Murphy sign present in 1/3 of patients. So the sonographic appearance is kind of non-specific for gangrenous, but you're going to have the same thing like the thickened irregular gallbladder wall with hyperechoic and hypoechoic striation, suggestive of gangrenous. Cholecystitis, interluminal membranes from sloughing off, and fibrous strands may be visualized on sonography. Gas within the gallbladder wall, absent gallbladder wall or abscess may be present. So best thing to do again is take the gallbladder out. I'm not going to make you know this, but just know there's a couple of types of gangrenous. Just know what it is. This patient is acutely ill. Gallbladder wall is thickened and sludge is also noted. Here's another one. Those arrows and C, air is seen within the gallbladder. Wall is also thickened. A stent or arrow is put where the arrow is placed within the gallbladder in a patient with gangrenous cholecystitis, patient acutely ill and unable to have a cholecystectomy, note thickened gallbladder wall and ascites. So this patient's super sick. So going under anesthesia is not going to work. So they do a different like IV and stuff to help with the symptoms and to cure. Gas forming bacteria invade the gallbladder wall, lumen pericholecystic spaces, and occasionally bile ducts and emphysema cholecystitis. It's more common in men. 40% cases are in diabetics. Gas bubbles is the main thing for this kind. Prominent non-gravity dependent changing position with patient. Air appears as echogenic foci within the gallbladder wall. Lumen causes gallbladder wall to appear echogenic. In critical patients, percutaneous cholecystostomy and IV microbial therapy used as temporary treatment in critical patients where they can't get their gallbladder out. Here's some air. This is what air looks like. Patient supine. This is what air looks like. Sometimes you'll see air in the uterus too, in the endometrium. So that's what air looks like. It's like almost looks like a stone. Which imaging modality of the gallbladder would distinguish between pus and sludge? MRI probably would be the best for that. Which complicated cholecystitis uses Neimer classification? And it is B, gallbladder perforation. So I think we're going to stop here, and we'll pick up next week. What I want you to know is when you're starting to study is we went over a lot of different conditions and just know like the definition of them and their sign that makes them different than other things. So like with the emphysema and cholecystitis, we're dealing with air. With gangrenous cholecystitis, there can be striations. So that's kind of what I want you to know and study, and then we will pick up next week. So, all right, have a good week.